Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of a 45-year-old young woman who presented to our ER with complaints of acute onset of paraplegia. Can we begin, sir?
Yes.
So there was this one 45-year-old female who presented to our ER with just complaints of acute onset of paraplegia. By acute, I mean 2 to 3 days history of paraplegia to an extent that it was all, at first it was just paresthesia, then sensory involvement, then motor involvement to an extent that she became non-ambulatory.
Okay.
Now that also was an issue from past 2 to 3 days, but she did not present to the hospital right away. Now the reason why she came in is because last she passed urine was that morning 6 o'clock and she presented to us in the night.
Okay.
So more than 12 hours she could not pass urine even though she had the sensation to pass urine, which is why she presented.
When we talk about paraplegia, first thing you should understand paraplegia levels. You should think and ask the question to the patient whether patient started weakness in the lower limb distalmost part, or the weakness started all of a sudden in all the muscles like proximal and distal simultaneously. What was the sensory involvement, whether that started as all of a sudden or it ascends up or descends down, whatever it is. Any other associated features like when the bladder is involved, when the bowel is involved, that chronological order will give you the diagnosis. If you tell paraplegia means it is nothing. Okay. So chronological order in neurological disease is very, very important, especially when you don't have a facility to take MRI or CT, because sometimes you'll be working in a peripheral setting where acutely will not get MRI facility. You'll have to send for some MRI scan center. So in that case, you need to have proper history.
Yes, sir. In this patient, she said that it was first sensory involvement. She felt that tingling numbness sensation. Then after that, she realized she could not feel anything when she was like walking around. And then from there, she said it was more like ascending, which is why we had other DDs in mind. But now we started like the examinations. So in our initial 10-second assessment, patient was conscious, oriented, obeying to our commands. We moved on to the primary survey.
So if you know the pyramidal tract structures or sensory structures, you'll understand. Sensory tracts are most peripheral if you are taking, and it starts from the sacral, lumbar, thoracic, like that. Okay, so that if you should have that orientation also, how the tracks go, how the tracks are arranged. Okay.
So then in our primary survey, airway did not seem there wasn't any compromise in the airway as she was like talking to us, comprehending, no anatomical deformities, nothing was seen. So in breathing wise also, breathing was pretty much normal as she had adequate chest excursions. So respiratory muscles seemed to be normal, adequate chest expansion was there, air entry was bilaterally equal. So and no crepitations or rhonchi were noted on auscultation.
Why in paraplegia we are worried about lung? Because anyway you have to take a history. I'm not telling about that. Should we worry about lungs and like other structures?
Yes, sir. Because ascending paralysis, if let's just say if it goes up, then respiratory muscles, if it is involved, then the respiratory effort goes down, and if respiratory paralysis happens, then this patient will be a candidate for mechanical ventilation, like we see in GBS.
When you are talking about ascending paralysis, you are talking about GBS. Can GBS stops in between? Suddenly it stops some position, one position, and will not progress?
I think it
is possible. See, any patient who is having GBS, it may be progressing according to this history. Suddenly the disease process can halt, or when we are giving some treatment, it can stop there. So paraplegia may not go to the upper part. So patient can present with even paraplegia and GBS.
Yes, sir. So then muscles were upper part of the body did not seem to be involved. So myasthenia and all were not really muscle dystrophy and all we didn't really think of at this point in time.
Muscle dystrophy is not a condition to be thought in this type of condition. Myasthenia is okay, but even then myasthenia recovers at one point. It has myasthenia aggravates and recovers. Okay, can any brain involvement be there in paraplegia? Because normally when we are talking about paraplegia is spinal cord. Okay, can brain involve? Unpaired ACA infarct. Unpaired ACA infarct. Normally ACA, anterior cerebral artery, is paired. If one side is blocked, other side will supply. Some patients will have an anatomical problem that only one pair will be, that will be supplying one side, both sides. Okay, one artery will be there, that will supply both sides. So if that one artery is blocked, patient can have lower limb weakness. But will they have sensory weakness?
ACA doesn't have sensory
Okay,
involvement.
so there is no sensory involved. Will the bladder involved?
Bladder comes in the front. Frontal lobe bladder is there, no sir.
Bladder like this, it will
Maturation
not be
center.
involved, but they can have social inhibition.
Social,
They will
frontal.
pass urine without any inhibition. Okay, so that is the difference between a unpaired ICA territory infarct producing lower limb weakness and spinal cord lesion producing lower limb weakness.
Okay, sir. So this patient had a normal respiratory rate of about 20 cycles per minute and maintaining saturation of 98% in room air.
Okay.
Now moving to the
If
circulation.
this patient suddenly, we are thinking about more in terms of emergencies. This patient is having last 3 days lower limb weakness, bedridden. So now in emergency room, she come with breathing difficulty. What will be your first differential diagnosis?
GPS, ascending paralysis,
Diaphragm involvement.
trauma.
Sudden onset of breathlessness in a patient who is having paraplegia. What is your differential diagnosis?
But DVT, pulmonary embolism.
That you have to think. This is a way to think. I'm not telling every patient in emergency room with breathlessness can have a pulmonary embolism, but somebody like this, present with acute breathlessness, DVT and pulmonary embolism has to be ruled out. Like you told, it can be GBS, but it's a progressive disease. Okay.
So then circulation wise, patients all peripheral pulses were palpable. Respiratory heart rate was about
Some pulses are absent. What do you think?
PVOD. Pulses being absent.
In a lady like this, if some pulses are absent and she is having paraplegia, what do you think?
Trauma.
You have to think about arthritis. Different types of arthritis are small vessel, large vessel, medium vessel. And large vessel and medium vessel arthritis, you can have absent pulses. And the same patient can have all types of complications. Like spinal artery thrombosis can be there. She can have weakness. So pulse has got very important role when somebody is having a paraplegia. Okay. Every clinical finding has got its own value in a given patient. Don't think that pulse is not useful. Other things are not useful.
Okay, sir. So in this patient, all peripheral pulses were palpable. Heart rate was around 84 beats per minute, and blood pressure was 130/80. So then circulation-wise, we did not really find anything abnormal. Now disability-wise, she had full GCS, 15 on 15, conscious, comprehending, obeying our commands, and pupils were also reactive, 2.5 millimeters. Reactive to light. Now in the deficit part, patient was paraplegic. The only thing the patient could do was
pupillary asymmetry is there. Patient is having lower limb weakness. What do you think?
Pupillary asymmetry is brain.
It's only in
Oculomotor.
It's only in brain.
That local thing. Multiple sclerosis.
Can thoracic lesions can produce pupillary asymmetry? Sympathetic tract descends up to that. What is this syndrome in lungs you get now?
Pancoast. Horner syndrome.
There also you get pupillary asymmetry. Horner syndrome.
Horner syndrome.
So everything we have to check. Okay. So if there is a thoracic lesion, you can get all these finding. Okay.
So in this patient, disability-wise, patient was paraplegic. The only thing that she could do was just flicker her toes, and that wasn't that very evident too.
Okay.
Other than that, no other thing, and plus she had no sensations at all. Okay. In fact, up until her umbilical area down below, she could not feel anything.
So umbilicus is a landmark. It is what is the root value of umbilicus? T10. So T10 onwards, she is not having sensation. Okay, there is a strong demarcation. So where will be the lesion in the spinal cord?
T8.
It can be -3, T7 or T8, whatever it is. Okay. -3 from this T10. So you have to focus on that area. Once you see a sensory level, then that is a clear-cut demarcation where the problem in the spinal cord. Okay.
So this was her deficit part, but upper limb seemed to be majorly unaffected. She was like able to move, but resistance she was not full 5, but to some extent
upper
resistance
limb,
was
you want
there.
to do any test like that in this type of patients? There is a thoracic lesion. Can you get any findings on the upper limb? Here there is a sensory level. Thoracic 7 or 8, there is a lesion. Can you get some abnormality in the chest and all? This type of patients. Patient can have autonomic dysfunction features. They can have increased sweating above that level. because autonomic dysfunctions are very, very common up to T10. Okay, so you have to look for that. Okay, autonomic dysfunction like hypertension can be there, hypotension can be there, tachycardia can be there. So we don't know where exactly is the lesion. Since she told it is somewhere around T7, T8. Okay, so we have to check all these things.
Okay, sir. This was her disability part. Exposure, there wasn't anything. GRBS was 140 milligram per deciliter. Temperature was normal. Afebrile. Then in our primary adjuncts, there wasn't anything much that we could have done except for taking an ECG that we did, and that's the only primary adjunct that we did. Then moving on to the secondary survey, sample history, symptom-wise, the thing is the patient has a history of lower back pain since November, December of last year. So from good 2 to 3 months of back pain she's had, and she's been on and off NSCs for her back pain. And then she also had complaints of constipation since 4 to 5 days. And urinary bladder was involved. That day's morning, there was like acute onset. She was not able to pass urine. So these were the acute symptoms that she presented with.
So bladder symptoms can be divided into UMN bladder and LMN bladder. Is this UMN bladder?
UMN is spastic bladder. So this was not spastic. This is more like spastic is patient won't. This is flaccid bladder.
Flaccid means what?
Flaccid bladder means the urine gets collected, patient is not able to like void. Spastic is patient just cannot control. It just keeps incontinence.
So you just tap on the abdomen, patient may pass. But in acute spinal cord injury, initially it will be flaccid. Okay. Any weakness below that level can be flaccid for some time. And after some times it will become spastic. Okay, so we don't know whether it is a actual UMN bladder or LMN bladder, since it's an acute problem. It can be a spinal shock, and all reflexes below that, including bladder, can be LMN type of weakness. But after sometimes the bladder function will become UMN type of bladder.
Okay, sir.
But whatever it is, as an emergency physician, what is your role there? Somebody is having it. So immediately we have to catheterize. We have to document what type of problem she is having. Catheterize the patient. Okay.
So then the other complaint that she came, symptoms, that was that paraplegia was her other complaint. So these were the symptoms that she presented with. On the negative things that we ruled out was any history of fever, any antecedent viral illnesses that she has had like in the last 1 to 2 weeks, which all of those symptoms were negative. History of trauma we asked. There was no history of trauma, no history of vomiting, headache, brain increased ICT symptoms were also ruled out.
Diagnostic procedures.
Recent interventions, she did not undergo anything. No, sir. No spinal surgical interventions were done in the recent time.
Okay. No investigative or diagnostic or
nothing.
Anesthetic.
No trauma also, sir. So in the past history, she did suffer from COVID the last year, and at that point in time she was hospitalized to an extent that she was even ventilated, and she was recovered from mechanical ventilation. And at that point in time she also had hemoptysis because of the involvement of Rasmussen's artery. Cavitary lesion was there.
What is Rasmussen's aneurysm?
That from pulmonary artery there will be a branch which generally in cavitations like TB cavitations and all, it can like bleed into the cavity.
Okay. In a cavity, when there is an artery, it will become aneurysm because it is not having any support and it can bleed. Okay, that is Rasmussen's.
So
commonly seen in TB.
So she had coil embolization done for this aneurysm last year.
Okay, so she mostly had a past history of TB.
So this is the only past history that was significant to note, and other than that there was no history of any recent surgical or medical history, no hospitalizations in the recent past. So this was her sample history. Then after sample, then examination wise, patient's general condition was like normal, and moving on to the CNS examination, patient bulk was like okay in all the 4 limbs, like good in all the 4 limbs. Tone examination, upper limb was normal, but lower limb it was spastic.
Okay. Hypertonia.
Hypertonia was noted in bilateral lower limbs, and it was pretty much symmetrical also. And power-wise, proximal, distal, everything was like zero. She could not.
Okay. Only flicker of movement was
only
there in
flicker
the
of the toe. A slight flicker of the toe. That was all the movements that we noted in her. And reflexes-wise, patient had absent reflexes, bilateral lower limb absent reflexes, but upper limb, biceps, triceps, supinator, that was present, including the jaw jerk.
Okay.
Then sensory level, like I mentioned, sir, no sensations. Even to pain, no sensation up until T10. Then from umbilicus to the xiphisternum, that is T8, patient had sensation, but it was little decreased in intensity. Like she could not appreciate it as well. She appreciated in the upper part of the body. So sensory level was T10. Motor level, like I mentioned, reflexes were all absent. So L3, L4, knee reflex, ankle reflex, everything was not there. In bilateral plantar was also mute.
Okay.
So this was our sensory examination, and then other systemic involvements were within normal limits, like respiratory system, cardiovascular, abdominal. We did not find any abnormality.
So you think
Comorbidities, like I mentioned, diabetes, hypertension was not noted. The only thing that she had significant enough to be noted was her past history of COVID and Rasmussen's aneurysm, which was embolized.
Okay. Anal tone.
Anal tone, she did not have anal tone. It was absent.
Okay.
So these were her findings, sir, clinically. At this point in time...
So you know the root value of all these reflexes? What are the root values of... you can start from the upper limb. Because this is a basic thing. What are the reflexes you have?
Biceps is C5. C5 is biceps.
Supinator.
Then supinator is by... C5, C6... No, C7, C8 is triceps. This
You
is
are an emergency patient, you
T1.
cannot think too much. C5, C6,
C7.
Then abdomen, what are the reflexes? You think about superficial reflex. C7 is over. Then
this is the abdomen.
think about 8. T8, T9. T10 is umbilicus. T9.
Then
T9,
iliac, and this one is
iliac area
T12. Inguinal area is T12. Then anterior thigh is L1. Then mid thigh is L2. Knee reflexes is L3, L4. And then that will become L5. Ankle will become L5.
Plantar is L5, S1. Angle is S1.
S1.
So it's a continuous flow of your root values. So if you know this root value, you know exactly where is the problem. Okay. You asked about anal reflex. It's absent. What is the root value of that?
That is S1.
Angle is S1. After that,
S2,
S2, S3, S4. So if that is absent, then they are involved. Since it is a spinal shock, they are absent. Okay. After sometimes if you examine, it will become a human type of reflex. Okay. It is very, very important to know the root value. As an emergency doctor, you should know the basic root values. We are not talking about deeper root values. Okay.
So then at this point in time, this was her clinical examination, and then we asked for examination wise, like after this we sent for blood investigations. In the blood investigations we sent for the whole control full blood count along with CRP and ESR.
Okay.
ESR, we did it in order to rule out any port spine lesion. ESR being highly elevated, we can think of TB. So
It's not like that.
More than
See,
100
ESR is elevated, nothing. It shows that it's an inflammation. You have an abscess due to something else also, it will be elevated. TB also, it will be elevated. It's an old thinking that high ESR indicates TB. It's not like that. Any condition, ESR can be elevated. CRP also indicates inflammation. Okay. When it is our duty to find out what is the inflammation. Okay. Only with the high ESR more than 100, you cannot make a diagnosis of TB. Okay. But TB, it is always high. ESR is always high. CRP is always high. We cannot tell it is more than 100, it is diagnostic. Okay.
So at this point in time, after that, in the blood investigations, total count came up to be 26,500. CRP was 78. Neutrophil
You are not thinking anything other than TB. That is a problem. See, we have to think, it is in the, according to you, it is in the T7 or T8. Okay. That's the area you get infiltration from the lungs. One of the commonest condition is always TB. But other conditions, she is a female. Like your patient is a female. What all other differential diagnosis you think about, and what are the areas you will examine?
If she's a female, then any
Breast examination is very important. You have to take an X-ray and rule out malignancies in the lung. You have to examine lung for TB. Breast is very important. Breast malignancy can have infiltration to axilla or your spinal cord, because that is the area where most of the infiltrative disorders can occur from either thoracic area, lung, or whatever it is. So, in a female patient, breast examination is very, very important. We don't know whether it is a TB or malignancy at present. Okay, so, examination of breast is very important.
Our DDs at that point, GBS was ruled out because
Why GBS is ruled out?
patient had
You can strongly rule out GBS. Why? Sensor is involved, bladder is involved. Both is not a part of GBS basic diagnosis. Very rarely some amount of sensation can be involved in some variants, but actually GB, if you are telling, it is only it is a motor weakness. Okay.
Then our next TT was transverse myelitis.
Okay, there you get all these things. Okay.
Then
so can you get transverse myelitis in TB without involvement of abscess like this?
I don't have ideas.
Vasculitis, spinal artery involvement by TB can present with transverse myelitis. Okay. So it is a vasculitis or immune-mediated involvement of spine is known in TB, but the common presentation is always TB spine is pot spine.
Okay, sir. And then the next series we thought of is compressive myelopathy.
Okay.
Either because of any tumor or infection, any abscess, all of this compressing on the spinal cord can present like this.
Okay.
And then syndromes like cauda-equina syndrome.
Do you think it's cauda-equina syndrome?
Because bladder tone was absent along with it, so cauda-equina.
What is the difference between cauda-equina and conus medullaris?
So cauda-equina affects the last part of the spinal cord.
Okay, so equina means that hair.
That's the hair part.
That is involved.
And the conus medullaris, it's
spine is involved.
The spinal cord.
What is the basic difference between these two?
This is flaccid. Cauda is flaccid bladder. You will
flaccid
see along with
and
asymmetrical.
Other one is spastic and symmetrical. But since it is acute shock, we don't know whether it is a UMN lesion or LMN lesion. So after 1 or 2 days, it will become like a UMN type of weakness.
Then any vertebral osteomyelitis, disc infections also has to be kept in mind.
Okay.
So with all of this, we had sent relevant investigations, like I mentioned, a CBC, CRP, ESR.
But here we are not suspecting cauda-equina and conus medullaris. Why?
Really following a trauma.
Most important clinical finding in spinal cord lesion is the sensory level. Sensory level, if you are getting, then the lesion is that area. Not below that, not above that. So it's a very, very specific finding in spinal cord lesions. So you are getting a sensory level at T10. It cannot be explained by GB syndrome. It cannot be explained by conus medullaris. It cannot be explained by anything else. Okay. It's a spinal cord lesion at T8. Okay. That's why you are getting a sensory level, whether it is transverse myelitis, compressing lesion, acutely collapsing of the vertebra, whatever it is at T7, T8. Clinically, it can be an extensive lesion in MRI or CT, whatever it is. Okay.
So ESR came up to be 100.
Okay.
With total infective parameters were elevated. CRP was 78, total counts was 26,500.
Okay.
With neutrophils 90.5 and lymphocytes was 4.24.
So total count is very much elevated. Can you explain this high total count by tuberculosis?
No, tuberculosis will not have this.
What is leukemioid reaction?
After the when you start the treatment.
Leukemioid reaction.
Very high total count.
Very high total count without leukemia. It is not due to infection, it is an inflammation. Inflammation somewhere in your body, like tuberculosis, rarely can produce leukemioid reaction. Okay. So leukemioid reaction is not leukemia, not infection. Like infection, bacterial infection, you can get this much high count. But patient is not having any infective focus like that. Bacterial infection is not there. Some inflammation is going on. That's why bone marrow is reactively producing. Sometimes lymphocyte can be predominant. Sometimes neutrophil can be predominant. but it's an inflammation somewhere else. Sometimes it can affect the bone marrow also. TB can affect bone marrow. So initially there will be increased production that gives this very high count. So high count doesn't mean that it's an infection or a malignancy.
Sir, and just another thing that I forgot to mention during the examination part, we checked for the spinal tenderness. The spinal tenderness, we did find it somewhere in the area, the thoracolumbar area, between T6 to T78, that area we did find local tenderness of the spine was also noted in this patient. I didn't happen to mention it earlier.
Okay.
Then,
From tuberculous abscess, can you suspect in terms of hygienic?
sir, most common cause of epidural abscess is actually Staph aureus.
Pardon?
The most common cause of epidural abscess overall is Staph aureus.
Okay.
Mycoplasma tuberculosis was suspected in this patient because of the past history of Rasmussen's artery aneurysm. Otherwise, our first DD will be a Staph aureus causing epidural abscess. And if this patient in IV drug uses, it will be E. coli.
Hematogenous spread from even urinary tract or respiratory tract or soft tissues, we have to keep in mind.
Yes, sir. The
C-reactive protein.
C-reactive protein was elevated, sir. It was 78.
Okay.
So, causes of spread can, like you mentioned, any major cause will be hematogenous spread. Otherwise, it will be direct inoculation following any surgical interventions, or it can be because of any superficial skin infection, or the infective tissues spreading can also cause this thing, along with vertebral osteomyelitis. Risk factors will be like diabetes, trauma, alcohol. All of this has to be like noted in these patients. Then apart from this, MRI was done, sir. MRI of the spine with contrast was done in order to find out any, because at this point we were quite certain that it was a compressive myelopathy. Infective or metastatic, we weren't aware. So we did a MRI brain with contrast, and the result came up to be spondylodiscitis. MRI spine with contrast. Result was spondylodiscitis from D6 to D9 with epidural connection causing cord compression. So our clinical history was quite consistent with the MRI finding. So empirical treatment was already started with antibiotics in this patient.
What empirical treatment you will start as a ER physician?
A broad spectrum that covers up MRSA, and also ceftriaxone 2 gram will also be added. Other regimen will involve flocloxacillin also 2 gram given every 6th hourly, or we can give, if renal functions are fine, vancomycin along with ceftriaxone combination can be given. Vancomycin in the dosage of 15 to 20 milligram per kg given every 8th to 12th hourly, and ceftriaxone 2 grams every 12th hourly can be given. This is the most common regimen that we use, provided renal function tests are normal. And the regimen will last for about 4 to 8 weeks, because it will take a while before the infection subsides. But if the patient presents with neurological deficits, like in our case, surgery has to be done within 24 to 48 hours in order to avoid or prevent further deterioration of the neurological weaknesses. So the minute we figured that this patient has a cord compressing abscess, we placed a call to the orthopedician for emergency surgical procedure.
What about TB treatment, anti-TB treatment?
That since it wasn't really proven to be TB, we have just been evaluated it. Patient was not started on empirical ATT at present.
Okay.
But we have sent for relevant investigations. If it turns out to be pod spine, then perhaps ATT will be initiated.
Okay. Ideal situation, if you are seeing such lesion, immediately better to start ATT, because once you lose the spinal cord, you cannot replace it. Okay, nothing wrong in starting and stopping the drug after it's de-escalation therapy like antibiotic. So in a situation like this, we have to start ATT and we wait for the report to come. If it is not TB, you can easily discontinue the treatment. But if it is TB, you will be losing a lot of time. You will not be able to save the spine. Here already destruction has occurred. So it is better to start as early as possible.
Okay, sir. So now when we discuss about the epidural abscess as such, most common region will be the thoracolumbar region rather than any other part of the spine. And risk factors, like I mentioned, IV drug users, any recent surgical interventions, spinal, either therapeutic or diagnostic interventions, or if the patient is alcoholic, basically low immune thing, or any spinal infections, all of this can cause epidural abscess. Then yeah, that's about it. So then we basically investigate and then confirm the clinical finding with the neuroimaging, and once that is done, we start with antibiotics and surgical management of this
As
patient.
a emergency doctor or as a doctor who is working in ICU, what are the precautions or what are the measures you take for this patient?
Now, this patient, since she's paraplegic, chances of DVT is high, so DVT prophylaxis has to be started, and physiotherapy also has to be given. Then that pneumatic socks, that compression socks.
Then, other than that, anything other than
Interventional bed sores.
Bed sores. Bed
bed
sores.
sores? Okay, then
Pain,
pain control.
pain
Then
control.
Bladder catheterization.
Urine,
you
that
have
we
to tell everything. You
catheterize.
see, if you don't remember all these things, many things you'll miss. Then
We catheterized. We
you want to
did the
cardiac
dressing
monitor this patient.
for infective and
Where is the lesion? It is in thoracic
TC.
spine. What is the problem in thoracic spine involvement in ICU?
spine, abdominal muscles. There.
You think about autonomic nervous
This
system. It extends up to where? What level? It is in the upper thoracic area. Here it is, luckily it is in the lower thoracic area, but it can involve in even the, you are not seeing. Sometimes it can go up also. So you have to be very careful. This patient can develop different types of arrhythmias, hypotension, tachycardia. So many things can be possible. Somebody is having a spinal cord lesion in the upper thoracic level, they can have autonomic dysfunction and lot of issues can occur. We have to be very careful when handling this patient.
Autonomic
And spine
dysfunction.
damage can occur while transferring this patient. So that also, we should handle this patient as we handle
Trauma
trauma
patients.
patient. So that also we should be very careful.
Yeah, that's about it.
Okay, where is a common lesion of TB in spine? Which all areas?
Thorax,
It is
thoracic
in the
area.
T10 area, T7, T8, T9, T10, that area. Mostly malignancies and other things all are in the upper
Thorax
spine area. But you can have prostate related malignancy can be anywhere in the spine, and it can be in the lower spine also. Multiple myeloma can be there in the lower spine, but that also can be anywhere. But lung lesions like TB or lung malignancy all are in the
Upper
T10 area, T7, T8, that area. So if you have somebody like that, TB is one of the strongest diagnoses. So from early itself, we have to start ATT.
Okay, sir.
Okay.
What is MRI finding?
MRI finding spondylodiscitis from D6 to D9 area with epidural collection causing cord compression.
It abscess means it will not produce all this discitis and other things. It's a simple abscess means it will be only in the outside, may not destruct like this. So TB has to be a strong differential diagnosis.
Okay, sir.
What happened to the patient? They did surgery,
They have taken this patient for procedure.
spinal
Surgical
cord stabilization.
stabilization.
Okay.
Okay.
Thank you.
Thank you, sir.